A 65-year-old male presented with swelling and impaired vision of the left eye. I am showing you axial and coronal T2 weighted orbits MRI scans and an intracranial time of flight MR angiogram. Describe the findings.
Let me just study this for a second, right? The T2 weighted orbital MRI scans demonstrate marked dilatation of the left superior ophthalmic vein. There is a prominent flow void within this dilated vein, indicating high velocity flow. The surrounding intraorbital soft tissues show mild congestion, but no compressive mass lesion or retroorbital tumor is identified. The time of flight MR angiogram demonstrates normal major intracranial arterial anatomy. Crucially, there is early, high-intensity flow signal seen within the left superior ophthalmic vein on this angiographic sequence.
I'm showing you a magnified view of the orbit. What is the diagnosis, and what is the differential for a dilated superior ophthalmic vein?
The diagnosis is a left-sided caroticocavernous fistula, which represents an abnormal shunt between the internal carotid artery and the cavernous sinus. The differential diagnosis for a dilated superior ophthalmic vein includes cavernous sinus thrombosis, isolated superior ophthalmic vein thrombosis, orbital pseudotumor, Graves' ophthalmopathy, and an obstructive retroorbital mass. A caroticocavernous fistula is distinguished by the presence of fast, arterialized flow within the vein.
Explain the classification, etiology, and clinical presentation of caroticocavernous fistulae.
Caroticocavernous fistulae are classified as direct, which are high-flow communications usually due to trauma or aneurysm rupture, or indirect, which are low-flow communications involving dural branches. In older patients, they often occur spontaneously due to atherosclerotic rupture of the internal carotid artery wall. Clinically, the increased venous pressure results in a triad of pulsatile proptosis, chemosis, and a subjective or objective orbital bruit in 50% of cases. Severe or rapid loss of visual acuity can occur due to compromised retinal perfusion and increased intraocular pressure. Extraocular muscle congestion can also lead to painful ophthalmoplegia, most commonly involving the 6th and 3rd cranial nerves.
What are the key radiological features of direct and indirect fistulae on MRI, CT, and conventional angiography?
On MRI or CT, features include a dilated superior ophthalmic vein, enlargement of the ipsilateral cavernous sinus, and thickening of the extraocular muscles. In chronic cases, you may see widening of the superior orbital fissure and focal cellar erosion. Conventional catheter angiography remains the gold standard, demonstrating early opacification of the cavernous sinus and superior ophthalmic vein during the arterial phase. Angiography also allows determination of the exact site of the fistula and mapping of venous drainage pathways.
Discuss the management and treatment options for this condition, particularly in the acute setting.
Emergency endovascular intervention is indicated if there is progressive visual loss, severe proptosis, or signs of cortical venous reflux. Endovascular therapy is the primary treatment, involving transvenous or transarterial embolization using coils, liquid embolic agents, or detachable balloons. Some low-flow indirect fistulae may resolve spontaneously or can be managed conservatively with carotid massage. As a radiologist, I would recommend immediate referral to an interventional neuroradiologist for diagnostic, digital, subtraction angiography, and emergency embolization to preserve vision.